So the next speaker is Dr. Andrew Knight. Dr. Knight has been a general practitioner for 30 years. He is a clinical academic at the Southwestern Sydney Academic Primary and Integrated Care Unit, where he is currently acting director and a conjoint senior lecturer at the University of New South Wales. Andrew has been chair of the Nepean Blue Mountains Primary Health Network since 2014. He's been a leader in GP quality improvement since 2002 through his role with the Australian Primary Care Collaborative Program, which worked with over 2,000 general practices and Aboriginal medical services to improve chronic disease care. He is director of NPS Medicine Wise, a not-for-profit company which promotes the quality use of medicines and medical tests. Dr. Knight?
Well, thanks everyone. It's great to be here to talk about this topic, the patient-centred medical home. When you start to talk about such things, people immediately start to reflect. What does it mean for me? If I'm a GP, what are they talking about? And if I'm not a GP, how does it affect me, the fact that we're talking about a patient-centred medical home? And so really it's a vision, it's an idea that we might want to buy into. And so it immediately provokes a couple of questions. One is, what is our shared vision for the health system? When you think about your own role, where do you fit in? What is my role in it and the role of the service that I'm involved with? I think there's a question that'd be good to bear in mind as we're thinking about it this afternoon. So I'm just going to walk a little bit through the patient-centred medical home in the health system. We'll think a bit about the medical neighbourhood, and there's a few implementation examples from my world that I'll just share with you to show how I think it's driving policy, this idea. So it's useful to understand it, I think. Why are we interested? Why are we thinking about this? Why is the patient-centred medical home important? It's become of interest because of the great interest in primary care. There's been an identification that primary care is really important for our health systems. You may have come across a series of studies that happened in the early part of the century, in the early 2000s, from Barbara Starfield and her group, where she analysed health systems around the world, in the US and all around the world really, and analysing outcomes compared to the commitment of that system to primary care. And the team found a number of things. They found that strong primary health care in a health system is associated, it has reduced system costs, better outcomes, and actually reduces the impact of social inequalities. So the great catch cry that you used to hear was that an extra GP per 10,000 people was associated with a 5.3% reduction in average annual mortality. So it's a big call, and it resonates. But it was 15 years ago now that this work was done. So is it still true? Interestingly, a study came out just in February analysing 10 years of work, 10 years of data in the States, and found something pretty similar. A big study. And so 10 additional GPs per 100,000, a 51-day increase associated with a 51-day increase in life expectancy. So by contrast, 10 additional specialist physicians, 20-day increase in life expectancy. 10 additional primary care physicians, about a 1% reduction in mortality for some chronic illnesses. So there's a recognition that we really need to be thinking about primary care in our health systems if we're going to look at cost, look at quality, look at patient experience, the triple aim that we're trying to achieve in terms of improving quality. How do we do it? What are the ideas that we think are going to make a difference? One of the big ones that's emerged over the last decade is this idea of the patient-centred medical home. And that's what I'm going to talk about. Now, I first heard about this at a conference, I think in 2010 in Brisbane. I was sitting in the audience, and there was a bloke called Paul Grundy speaking. He was the head of health at IBM. And IBM, of course, huge company, spends a fortune on health. And Paul was a great proponent of the patient-centred medical home. And as I sat in the audience, I Googled it. I thought, what is that? I didn't know what it was. So, of course, up comes a whole lot of sites for what it is. And clearly, there was a lot of different views about what it was. There's also something about history. And interestingly, it's been around, the idea's been around for about 50 years. And it actually came from anaesthetists, amazingly enough. And so it was mentioned in this document in 1967, and the idea is traced back to this time. And you'll see that the anaesthetist realised that one of the major deterrent to adequate health supervision was the lack of a complete record, a medical home. And so they said, wherever a child is cared for, the question should be asked, where is the child's medical home? and any pertinent information should be transmitted to that place. So it becomes a repository for healthcare information. And that idea has been developed and thought about and thought through to the point where a number of other ideas have emerged. So when I Googled it, all these different places had different ideas. So one place had 7 principles of the medical home, another had 5 principles of the medical home, then there was another which had 8 principles of the medical home. A group of us got together in Australia after this conference and we did a bit of a round robin about what we thought. We had 11 principles of the medical home, and the College of GPs had a document with a number of principles of their own. So what I did was take all those 5 documents and put them side by side and try and work out what are the common ideas, what are the common themes or pillars of the patient-centred medical home. And the document looks a bit like that. I'm not going to go through it in detail, but we just went through and found where there was commonality. And where there was commonality were these 5 pillars. And they have really become internationally the 5 pillars of the patient-centred medical home. I'm about to go through them in a bit more detail. As we discussed them amongst our colleagues, we thought these 2 things were also really important in Australia. We have a sense that in some ways general practice has lost the sense of accountability for a group of patients and lost, too, the ability to provide some continuity. So we were certainly looking to provide some of these things in our formulation. So the 5 pillars, patient-centred care, very similar to the sorts of things Deborah was looking for. So a patient-centred medical home will acknowledge and act on cultural preferences and values of patients, will promote shared decision-making and patient self-management, which we know is very important for chronic disease care, and even to the point of getting patients involved in the design of the service. That's a big step for a private general practice, but it's something that people need to start thinking about. Comprehensive, responsible for the full range of physical and mental health care needs. So we're not dividing things up, we're encompassing generalism, including prevention, wellness, chronic care. Continuity, a lot of evidence emerging that it is continuity that is the magic ingredient of primary care. Where a trusting relationship occurs with a primary care clinician, we see better outcomes. Coordinated. So the team is ensuring patients are accessing the care that they need. The team in the patient medical home is working on integrating care with the patient and ensuring informational consistency and being accountable for that patient and a population of patients' care. Accessible. Again, a challenge in Australia where a lot of after-hours care isn't happening necessarily with the GP that you know. So you get to see your family doctor when required. And what's more, that practice reaches out to those who are not there, not just the people who are in front of you, but the people who don't come and should be coming. And accessibility will involve the use of different modalities for communication. So face-to-face is privileged under the Australian health funding, but we need to move to be using asynchronous electronic communication and other forms to improve accessibility. And finally, a focus on quality and safety. So patient-centred medical homes will have systems. They'll be committed to safety. The medical history will be curated and up to date. And the medical home will be committed to quality improvement as well. And that's certainly something that we've been working on over the last decade in the Australian Primary Care Collaboratives. All right, well, does it work? It's a difficult question to answer. It's a complex intervention in a complex adaptive system. Does it work? There are quite a few evaluations emerging. It's, of course, with all these things, takes time and the evidence is variable, but there is significant evidence of impact on the triple aim. So patient experience, outcomes, and cost, it does seem to have some impact on, and you can look at those articles from the slides. But how do you do it? What does it mean for me, again? What is our vision for the health system? Sure, the patient-centred medical home might make sense, but how do we get there? And a lot of GPs hear that and say, that's what I do already. And what if you're not a GP? How does the model help you in the role that you have within the health system? Well, we talked about this and worked through it, and I'm going to present a model that we think makes sense. You can have a think about it and see if it makes sense to you. It starts, of course, with the patient at the centre. And there's a patient icon in the middle of the circle. But of course, patients don't live by themselves usually. There's usually some dependents, maybe a spouse. And so that constitutes the home. The home is where most healthcare occurs. You're probably aware of Kerr White's Ecology of Medical Care study. Looked at 1,000 people and worked out their utilisation of health in a month. Of the 1,000, 750 people feel unwell in some way. 250 will go and see a clinician, usually a GP. 9 will be admitted to hospital. 5 will be referred to a specialist. 1 out of 1,000 will go to a tertiary institution. Now, that study has been repeated about 20-year intervals ever since, twice, and each time it's found something very similar. So we know that the majority of healthcare actually happens in the home. So in that home, most healthcare is happening. Now, the idea that we've got is that there will be a primary care clinician that will be seen as part of that complex, helping with the care that happens in the home and outside of it as well. And there will be a relationship between the patient and that primary care provider. But we know that general practice is less and less, as we know, as Robert was saying, less and less of an individual game and more of a team game. And there's a lot of benefit there. So there'll be nurses and allied health, and there'll be administrators and care coordinators and people analysing the population to make sure that people are getting the care that they receive. And so we have a medical home, a home wrapped around by a medical home. And that home will be further wrapped around by community services, community nursing, pharmacy, hospital in the home, ambulatory care, further complementing the services provided by the medical home. And of course, wrapped around that is tertiary care, hospital care, absolutely crucial, isn't it? That we have those services evenly and accessibly distributed to support the care that's occurring in the community. Now, that's the vision of how it could look, and we know that the more you move care to the left, all the evidence says, with people operating at the top of their licence, the care is closer to home, it's more acceptable to patients, it's also less expensive and potentially more effective. But if you need the care at the other side, you need in the hospital, if I collapse with my heart attack or I have my stroke, please immediately get me to the tertiary institution to get me to the care that I need. And we call that the medical neighbourhood. All working together, coordinated and communicating across those barriers, all working at the top of their licence to provide the care in the most effective way. The person-centred health system. So it might start simply with your relationship with your GP, but at times you'll need to extend that to other members of the practice team. If you need a dietitian, or you need a psychologist, or you need to be part of a population that needs extra care. Or sometimes you'll need people in the community, and sometimes you'll need to go to the hospital. Now, we're not, doing handover here. What we're doing is extending the team and contracting the team as required, as the patient requires, as part of the medical neighbourhood. Okay. In Australia, primary health networks cover and support that bit to the left, and local health districts, local health networks cover the hospital part. And so those groups are starting to build up the system. How does it help? Well, for general practice, I think it provides a vision for what we can be. I think there's a danger, for general practice that to an extent we may be losing our vision of what we can be and what we can provide. I think for patients, consumers, perhaps it offers a standard that can be demanded. Why don't you have those links? Why aren't you monitoring my care? Why don't I get access when I need to the places? Why isn't it connected across the continuum in the medical neighbourhood? For funders, it's an opportunity to think big about the system, to not start creating initiatives which break this. One pet bugbear is central call lines. They're very efficient, but they break down relationships. It means I don't know who I'm working with. When I call the telephone number, it could be anyone. Whereas it's much better for me to know the individuals in the medical neighbourhood and develop professional relationships with them. If you're in specialist care, where do you fit in? Well, of course, you fit in very importantly right through that system. But can you be moving further towards that community side of things? And what is the role of the hospital? Should we be making specialist outreach services from the hospital to the community? Or should we actually be investing that money in the medical homes and in the community? It's a matter of where the best investment can occur. So that's the vision. Now, it is having a significant policy impact. I think it's been talked about over the last 10 years. And those of you in your own health systems, you can probably reflect and think how some of the changes are being instituted that match with that vision. Here's just a few samples. In New South Wales, where I work, one of the pillars of the New South Wales Health, the state government-funded system, is a process to build healthcare neighbourhoods. They're calling it Navigating the Healthcare Neighbourhood. You can click on that link and it'll take you to a site that explains it. And they're doing lots of work with regions to build up medical neighbourhoods. Nationally in Australia, we've got a healthcare homes trial. It basically involves a number of changes: a chronic disease bundled payment in primary care, quality improvement in primary care, joint care planning right across that medical neighbourhood continuum. It's got a bit of bad press because there's some limitations with it, but certainly in our area in the Nepean Blue Mountains where we're doing it, we're finding that the practices are starting to get creative. They're starting to use that bundled payment to free up the way they deliver services. We're actually quite excited about it, and we're looking forward to seeing what the practices can do with that bundled payment and being freed up from the fee-for-service throughput model of care. In Australia now, 90% of people have their own online health record. So suddenly there's an opportunity to have informational continuity across that continuum. This is a system-level integrated principle, which in my view in the next 5 years is going to make a major difference. Again, in the Nepean Blue Mountains, we were one of the trial sites in the country, the first 2 sites in the country to do it, and we're finding people reporting that they're now getting information that they didn't get before. We'll see what happens. There's risks and challenges with it, but it seems to be having an impact. In August, a new payment for general practice will come into place called the Quality Improvement Practice Incentive Payment, where practices will receive an incentive for doing quality improvement. They'll need to submit data, outcome data from their practices. They'll need to participate in quality improvement. At the moment, 55% of GPs voluntarily give outcome data to their primary health network. We expect when this comes in August, 90% of GPs will be giving data, outcome data from their practices. Suddenly we start to get a picture across the continuum of the healthcare neighbourhood of what's happening in our system. And finally, just in the last budget, the government has announced that for people over 70 with a chronic disease, we're instituting voluntary registration with a capitation payment to practices where patients do voluntary register. So suddenly there will be more accountability from those practices for those patients. Okay. I thought I'd give you an example that I experienced when I visited Jönköping in Sweden, a place famous for the integration of its care and the quality of care that it provides. I visited, I don't know how to say this, Raw Live Clinic, I think. Amazing general practice. I've never seen one like it in Australia. We were walking through one of the clinic floors and I saw this on the wall. It's a piece of paper stuck to a whiteboard with magnets. And it was clearly a list of outcomes and indicators. And I said to someone, "What's that?" And they said, "Oh, that's our KPIs." I couldn't read it, it's in Swedish. But I took a picture of it and I got a colleague to translate some of it. And this is some of the KPIs that a Swedish general practice responds to and tries to improve. So in Sweden, a general practice knows the number of their patients that attended ED in the last month. They know the number of patients over 75 who attended ED. The number of their patients who required an urgent readmission. So they're discharged and then urgently readmitted. And then the total number of ED presentations. There's outcomes about continuity. They know how many of their patients were scheduled by name to their own GP. How many people saw the same GP the last 3 times. How many turned up and were admitted to hospital without being assessed by their actual general practice. And how they're going with holding their budget for those patients. Now, we don't have that data in Australia, but I think once we get a full system and data right across the continuum of the healthcare neighbourhood, we'll start to be able to make changes which reflect this. So that's the vision. We've talked about the patient-centred medical home, we talked about the medical neighbourhood. I wonder if you're reflecting and thinking that's not a vision I agree with, or that's a vision I do agree with. It's a vision. It may not be the right one, it may not be the best one. But if you don't agree, what is our shared vision for the health system? And what is my role in it?